Hey, everybody. It's been said that the only constant in life is change, and medicine and this podcast, no exception. So since this was recorded in 2022, there's been some changes to the EMS protocol that aren't reflected in this video. The first of which is TXA. Although all the administration and all the other philosophy about TXA discussed in this video is absolutely correct, the dose is now changed from 1 gram to 2 grams, given in exactly the same manner described in this program. The second is Push Dose Epi. Although in the program we refer to 10 mics every 2 to 5 minutes, that is now changed in 2 ways. The first is the timing is completely abolished. As soon as you know you need the drug, you can go ahead and give it to stabilize your patient. Furthermore, you may give up to 50 mics per dose as your patient requires to stabilize their blood pressure or heart rate. Hope you enjoy this operational pharmacology podcast. Caleb is bringing up I certainly get it. We currently have a fair amount of advanced EMTs that work with me. Is they're permitted to give oral Zofran, right, by state scope of practice and by protocol, but they are not permitted to give IV Zofran, right? And the state is, this is verbatim. This is the verbiage here from the state.
Okay.
And that is simply because there is a higher instance of QT prolongation with the IV.
Specifically IV.
Specifically the IV, right? And
I'm sorry.
yeah,
I'm thinking about a resident who came running up to me a couple weeks ago and said, Dr. Spanner, I actually gave, sorry. It's such a bizarre story. I actually gave IV Zofran, and they just handed me the EKG, and the QT is 524. Should I give magnesium? And I said, oh, is the patient in torsades? And they were like, not yet. And I go, okay, when they go into torsades, let me know. We'll give the magnesium.
have the mag on cue.
The reality of it is that the studies that showed Zofran on donsterone causes this torsades with this QT prolongation, potassium channel poisoning, if you will, is like after 32 milligrams in a 24-hour period. Right. So I have given thousands of doses, and yet this is one of those situations where you said you don't like politicians telling us what drugs to give and use because they're not medically trained, but somehow this happens. This is the same kind of thing where it's been gone through the legal channels, and this has become one of those situations. It reminds me of when I gave Haldol, hundreds of doses of IV Haldol
right? Yeah.
in the 80s and the 90s and early 2000s, and never once had a problem, and now it's this black box terrible warning for Haldol. I'm not poo-pooing what you're saying.
Yeah.
I'm just telling you that you guys are not going to run into these types of things. And yet here it is on our protocol. So because it's on our protocol, we need to be cognizant of it, is how I would like to look at that.
This is kind of out of our decision-making realm from the
Ohio EMS scope of practice.
From the scope of practice perspective, because you can't write a protocol that exceeds scope of practice.
Correct.
Right? And let's just look at it.
But I also want to be real.
Right. No,
I want to know what the reality of it is. So this is one of those situations that is now in our face, and now you have to get an EKG, and you have to check the QT, and then you have to assume that this could be a problem if the QT is over 500 milliseconds or 2.5 large boxes.
Yeah, how many hundreds of milligrams are given in your institution daily
without an EKG?
Zofran, of Zofran alone. Let's just enter that, and then how many cases of torsades are there in that same institution a day?
0.
A week, a month?
0.
Yeah, probably 1 or 2 cases, a year, right?
No. I've never seen torsades with Zofran. Never.
I was just speaking torsades as a whole, let alone.
But you're never going to get 32 milligrams of Zofran in the emergency department.
Certainly not in the ambulance.
And certainly not in the ambulance. And yet here we are.
I can absolutely guarantee that.
And so we will. Sure. I just want everybody who's listening to at least understand what reality is here.
Yep.
Sorry.
I think it's
But
good.
but the flip side of that is
We are where we are.
regardless of the reality, we're bracketed into
Follow the
advanced
rules.
EMTs can't give that because of that probably overstated or over concern for QT prolongation.
So now,
Overcaution.
so now Zofran is blue boxed.
No, it
No,
just an
advanced-
intermediate EMT cannot
advanced EMT,
give
yeah.
IV Zofran, only oral Zofran.
Oh, okay.
Yeah.
Okay.
So,
Got it.
are there any other, while we're talking about advanced EMTs, are there any other advanced EMT stumble blocks that really need? I mean, that's the one that always comes up. Why can't I give this?
Yeah, it's,
The other thing is, I think, why can't I, as advanced EMT, give IV epinephrine? I can only give IM for right, and they got to remember that they're not trained.
they're not looking at a monitor.
ACLS, right? They're not basic rhythm recognition and defibrillation, but they don't get the full-on ACLS course, right? And they don't get the full-on backstory of all things cardiology.
I can't think of any drug that an advanced is giving intravenously.
Oh, there's several. Yeah, I mean they can give
Analgesia?
analgesics,
Okay.
benzodiazepines.
Analgesics
They can give the
and,
antihistamine. They can give diphenhydramine,
Yeah.
IV as
Benadryl.
well. Yep. Mhm.
But it's epi that can't give IV, which
Yeah,
is
yeah, and that's for cardiac reasons. Right?
yeah. Well, obviously they're not reading 12 leads either, so
Also no. But yeah, that cardiology background that the paramedics have. I mean, we spend almost a quarter of our education in
On
class
cardiology,
just on cardiology.
yeah.
But there's an
alone.
easy solution though. They could take the bridge course to paramedic.
Also, yes.
And,
They could come visit. They could come visit us at our paramedic program,
And
we
we're
can- we
happy
can
to
fix that for
facilitate.
you. But not everybody has the time, the money, or the wantness to do so, and I understand that.
no, and I understand there is a role of the intermediate. I feel that's more. It's a little further east than most of this county, but they're there.
South.
And you would probably starve those departments of any EMS
Any advanced
resources if they got rid
provider,
of that. So
Oh,
there's a time
100%.
and place.
Yeah, you move
There's-
south, it's pretty popular.
South
Yeah.
too, yeah.
And a lot of times when we even put the protocol out, they're one of the first groups we call to, hey, go
Oh,
through
when I
this, call 'em
speak in southern counties, there's a lot of advanced.
Yes.
Yeah.
Yep.
And we're just very saturated in a lot of this area of paramedics and
Yeah. Well, see, that's not how the rest of Ohio is.
No.
Absolutely not.
No, we're lucky.
And we are lucky. You trip over paramedics here. And the way they utilize paramedics in Seattle, for example, you have to work at becoming a paramedic because they focus on very heavy EMT care, believe it or not.
Yeah.
And the paramedic is just there because of, the medications, as opposed to the EMTs where they focus on excellent CPR,
yeah.
and excellent controlling the airway without tubes, obviously. But, the reality of it is EMTs stand a very good purpose, and that's why they're utilized in these sparser areas in Ohio, and so are the advanced. As I think about all those green boxes in our protocol, there are a lot
There-
of drugs.
Oh yeah.
There's a lot.
Oh yeah. And,
It's
and
a
like
very-
I teach in my class, though, that a paramedic and an intermediate is only as good as a good basic or a good intermediate is
Yes.
to a paramedic. So
Well, what do you go back to when you're running into trouble?
your basics,
Go back
your
to your-
basics, and it's
and
going to take a good
ABC.
basic to say the patient's not breathing, or you're not bagging that patient correctly, because that's what they know.
So I got a high school student, soon to be a college student, following me around. That's their summer program. And I said, "What have you gotten out of this?" He said, "I got this one line that you said to the nurse, go back to your basics." I go, "In what context?" "You were taking care of a heart failure patient whose blood pressure dropped and they were on CPAP. And you said to the nurse, take them off CPAP. And I watched the blood pressure go right up. Then you explained about preload to me." This is a high school kid.
That's
and what does
awesome.
that tell you?
Yeah.
No, but
Can
what
we
does it
recruit
tell
them
you?
for that?
Go back to your
Do you
basics.
guys know Chuck Bach from Solon? It's his son.
Oh,
It's his son.
nice.
He's following me around for the
Oh,
son.
very nice.
It's a great kid. And a really smart kid.
Clearly.
But I mean, I wanted to know, what are you getting out of this? You know what I mean? And he says, "I get that you always say go back to basics, and your basic knowledge is what raised that person's blood pressure." And isn't CPAP a basic skill?
Yes. Yeah.
You got to know what that means then.
Yeah. Absolutely.
Well, you want to make Push Dose Epi?
Yeah, and just a second. I want to say one thing about advanced EMTs. It's a very, with the exception of the cardiac arrest
Yes.
piece of that, it's a very utilitarian, for medical emergencies, it's a very utilitarian level of practice. Amplifying what he said with the basics, we as paramedics, as advanced providers, rarely do our drugs make the difference. It's good CPR, it's good airway management, it's all that basic stuff that gives them the opportunity. Yes, sometimes we make them better. We have one-off cases where they're hyperkalemic or something like that, and our drugs do make the difference, but those are infrequent. It's often just the basic stuff. Yeah, the advanced EMT, very utilitarian scope of practice, despite a few little weird things that we have in Ohio.
Yeah.
Yeah.
So Push Dose Epi, I'm not making this one. Somebody else can make this.
Oh my God.
But
I'll make it.
so this is one of those things. I mean, we've been pushing it over a year now. I think we're
think about the advantages here,
into year
Scott.
2, right?
We don't have pumps in our squads.
Absolutely.
I mean, certainly we do have pumps in our critical care squads, but in our standard paramedic fire department squad, they don't carry pumps. And how many of them were ever using dopamine?
Correct.
And certainly dopamine, if you're using a drug like that, needs a pump. So actually, a doctor, Chris Myers, brought this to the regional area, and as soon as he was talking about it, I fell in love with it. I also had a policy that I've had my entire EMS medical direction career, which is don't ever ask a paramedic something you haven't tried, okay? Don't ask them to do something that you haven't done, okay? And so this really kind of freaked the pharmacists out because obviously I do vasopressin, right? I do levo, and I run those on pumps. I do epinephrine drips, and I run them on pumps. So I said, I called the pharmacy when we were talking about this, and I said, I want you to take 1 milligram, 1 milligram and 1 cc, and I want you to put it in a 100 cc bag of D5 and send it to me. Now, picture the pharmacist's face, right? He goes, yeah.
Where's the order set for this?
Right. He goes like this. He goes, what? And I said, listen, I have to do this because I'm trying to get paramedics to do this. I got to know it's safe, and I got to know that it's easy, right? And there's some really ridiculously easy things about this. Number one is the max dose at a time is 10 mics. So you're going to take this 1 milligram, which is 1,000 micrograms. You're going to put it in a 100 cc bag, and there's no math involved. And you just take 1,000 mics, divide by 100. I know I just said there's no math, but it's just to make a point, right?
No, I get it.
Well, 1,000 divided by 100 is 10 mics per cc, which is like a wisp of epinephrine, right? And you give that every 2 to 3 minutes until you get a systolic of 90 or a MAP of 65. But hold on, isn't there math with kids? No. If you think about, do you guys have babies? How old are your kids?
6 and 3.
6 and 3. How old?
7.
My dogs don't count.
Your dogs don't count.
No.
Okay. But they should. So anyway, the little ones, okay? Do you remember how much they weighed when they were born? Everybody usually knows how much their kid was.
6'14", I think.
Okay, so let's call 7 pounds, right?
Okay.
So every healthy child doubles their weight at 6 months. Every healthy child triples their weight at a year. So if your kid is a year and the dose of Push Dose Epi in children is 1 mic per kilo, they need to be 10 kilos to get the adult dose. So what you're telling me is, because I said there was no math, any kid that's a year old gets the adult dose of Push Dose Epi. And before that, it's just 1 mic per kilo. So we just reviewed a case in last month's training with a 10-day-old sepsis, Andy sepsis case, the 10-day-old, and the kid was 3 kilos. So it's 0.3 of a cc. Done. That's the hardest math you'll ever do with this.
Yep.
I mean, in a nutshell, this is easy. It's not a drip, and you get the effect that you want, specifically for septic shock and cardiogenic shock. So distributive shock and cardiogenic shock, those are really where you're going to need that. That's how I would lead into that.
As I train people on this, I remind them it usually takes 2 minutes or so to get a blood pressure back on your machine. So basically, you push the button. When you see a number, if you don't like it, it's time to do it. Time to do it again, right?
I like that.
The machines aren't instant. We have this instantaneous. Like, I get to instantaneous. You don't. It's not.
But you can also
it's not an art
set
line, right?
On our life pack, you can actually set the interval to 2 minutes.
2 minutes, right?
And every 2 minutes, you can look at that and say, okay.
But then it
the
takes a
machine
minute
does
or
it for
two
you for the whole
to
trip.
cycle, right?
Yep.
I
So
like
that's on
that.
top of that. So I just keep it simple, stupid. Push the button. You know,
KISS.
Yeah,
Keep
right.
it simple, stupid.
Push the button. By
Couldn't
the time
be
it comes
better than
back,
stupid, like keep it simple.
Scott. That's suggesting I overcomplicate
Keep it
things.
simple, Spanner.
It works.
Keep it simple, Saleb.
Sail up.
Keep it simple, Sray.
Ray, before you get into mixing this, we're gonna show you, or we're gonna talk about mixing it one particular way. But math is math. You can get this cut down to 10 mics by many different methods, right? And the reason we landed on this, and this was a discussion at amongst the regional protocol doctors, is we thought this had the least room for error, right? You're just going to take all of it out of a 1 milligram vial. Right? Ampule, if there's still a few ampules floating around, you can touch on that. But you're going to take 1 milligram, 1 milliliter out of there, just jam it in the bag, and then you don't have to worry about air because there's already air in the bag. So all you got to do is shake the bag, and it's
Not shake.
you don't have. Oh, I'm sorry.
Invert.
Invert rapidly, linearly in a linear fashion.
They get all skittish with that shake deal, especially with AMI.
Especially
The
AMI
AMI makes sense.
Very reasonable.
Gentle.
right?
Solumetrical, too,
Gentle.
will bubble up pretty bad.
Yeah. But the other thing is you've also made a bunch of it, right?
Huh.
So even if you got to use, let's say you had a prolonged case, right, and you've used that first 10 ml up, you've got more, or alternately, if you had to walk in the ED, you can hand it to them if they needed to urgently start a drip. There's
Yeah, because you got to think that drip's not going to come right away.
it's not instantaneous.
So, unless you have a clinical pharmacist in the ER, that's going to go make the drip. You're still losing that. You're still losing that person to make the drip, or you're waiting for pharmacy to tube it. So this is a good stopgap in between that drip coming down to the ER, I would think. We come in, hey, I could still use this. We cycle the first pressure. The nurse is standing there. Hey, we can continue this, and the ER physician's probably in the room too.
Have we done it? And again, there's labels
have.
in the boxes that you slap on here, and it tells you what you've mixed. And
I've used it, and I've used it like with zero problem, and incredibly effective. Do I usually need more than a cc? Yes, but it works really quick. It also comes off pretty quick, but it's a nice way to manage a situation, especially in the pre-hospital environment.
That's a great point. We have a lot of drugs that will work 10, 15, 20 minutes, right? This is not one and done.
No.
This is, you're going to have to keep
Continuous.
augmenting, right, and keep chasing that.
I just had, again, using names only for positive situations, I just had Avon Fire use this successfully. I just had North Ridgeville use it successfully. So I've got a lot of departments that are all over this, and it's done really well without literally any problems.
And we talked about this slightly on the last podcast, but I think it's worth repeating is, it is so simple and so easy. There's really few excuses to deliver somebody to you hypotensive anymore.
it's not dopamine anymore.
That's
So it's
such a good point.
Right? I mean, you should look at us cross-eyed because gone are the
Well, I
days.
do. This just like. I mean, I look cross-eyed. I'm like, what do you? Come on, guys. You can't
even
be
with
simple
dopamine,
in
you had to do
this.
that. You had to take away 2 math if you did the medic math. So this is
Right.
no math.
Yeah, there's no math, and
So simple.
despite everybody wants to argue, dopamine took time to set up. I don't know that it really did.
And initially, when this came out in protocol, when I was doing CEs, I went to 4 or 5 departments that month, and I talked about it, and they got a little bit,
Dear
wide-eyed,
yeah.
and I said, okay, but I brought a bag, I brought fake epi, and I brought syringes. We're going to mix it. who wants to volunteer, and ultimately somebody would be assigned,
Right, yeah.
and they come up and
Voluntold.
this isn't hard. Watch here, and they did it, and everybody was like, that was it. Yeah,
Yeah,
that's it. That's it. But
It's a super.
as soon as you do it, it's just like the humeral head that we went to the IOs. Nobody was comfortable with it because they were always used to the tib fibs. But the first time they did it, it was like, that's not that bad. No.
And likewise, if you have that case that is imminent, the trajectory of that case is likely to, I personally had a case last year where this patient's blood pressure was marginal, and every couple times I'd cycle that blood pressure, it's like, I don't know that I believe that. I double check, good radio pulses, whatnot. It's like, okay, the numbers are okay, but they're soft, right? So just mix it up, have it available, right? That way.
What's the worst case scenario? You have to visit the pharmacy before you leave to get another one.
It's terrible. But, I'm ready to go if I get, oh, shit, that map is, 60. That map is 55, right? You can get right on it. So if you need it, it's just Epi. It's cheap. Mix it up.
Specifically for our cardiogenic shock and our distributive shock. When I mean distributive shock, I mean sepsis and neurogenic. It is not the appropriate thing for anaphylactic distributive shock.
Safe to say all shocks except anaphylactic shock. Simple.
Well, no, in hypovolemic, whether it be
correct.
hemorrhagic, you're already vasoconstricted in hypovolemic shock, and they need volume or blood, and they need to stop the loss. In obstructive, certainly this would not be advantageous because the obstruction is what's causing
the hypotension.
lack of preload. So whether it be the tamponade, the tension pneumo, or the massive PE, this will not be anything advantageous to that. So you're really limited to cardiogenic shock, distributive shocks that are amendable to low dose push dose epi, meaning neurogenic shock and septic shock. The anaphylactic shock, break open that epinephrine, Ray. The epinephrine here is going to be 100 micrograms per cc, right, guys? And the 100 micrograms per cc is what's required when we're talking about anaphylactic shock, because they don't die on me. They die on you guys. Still to this day, we have about 300 people who receive penicillin injections who die annually from anaphylactic shock. Those folks are dead almost before the needle comes out of them. And the only chance they have is a aggressive, smart, ready to act pre-hospital personnel.
Point you just made, that's, you're going to use 100 mics of that. 0.1 milligrams per milliliter, which is that concentration, is 100 mics
Correct.
per milliliter. Yeah.
Right.
So you're talking about 1 milliliter every minute or so until their blood pressure, that anaphylactic shock patient,
Correct.
comes back.
People that are alive really don't like IV epinephrine
Shocking.
in high concentrations, but they don't mind that.
I've had
so
success.
So we use it. I always joke about our nursing home patients just because there's so many septic patients out of there. I mean, that's where I see
And you
probably
know
the
when you
most
walk in on
usage
it.
out of it, because let's say our dialysis center, our nursing home, we utilize it a lot just because you get a lot of septic patients out of there, and it's a go-to. It's easy to make, it's easy to give.
You have a
and
lot
there
of
are
nursing
2 bags.
homes where you're at?
Yeah, we do. We do. And then there's a couple bags in the box too.
Mm-hmm.
So a lot of people talk about, hey, I have to go get a new drug box. The nice part is I can make one epi drip. I don't need a new drug box, right? Because I have more epinephrine, and I also have another bag of D5 that
How
I'm gonna
many
mix
are
with.
in the box?
So there's 2 bags of D5, and there should be at least 3 amps or 3 vials, excuse me.
Yeah,
of
because you
epi.
need at least 3 if your racemic's no good.
Yes, yeah. So we usually have plenty within the box.
Why don't you talk about that?
all right.
About that vial, right?
All right,
Because
so
that's been a fight of yours for a long time.
you're
And
kidding.
thank you for finally pulling it off.
I didn't pull it off. It was their idea this time. So
Doesn't
we're very
matter who
lucky.
takes credit.
Well, you know
It
what
got
though?
done.
It got rid of the filter needle.
Oh
Yeah,
yes. So the
that's
shortage
huge.
the shortage of filter needles actually helped our case. Was part of that too. For a while there at Portage, we were actually tracking how many ampules we broke because we broke that many, right? And initially we stayed with the ampules of epinephrine just because it was cheaper. And then you have somebody that gets cut on the squad. That's just,
Really? That much cheaper, Ray?
it is. It's a lot cheaper. It's like, I want to say we were at like $9 difference or so.
That's
Maybe
all.
$10 difference.
That's also trade name drug.
Yeah, and that's the other
That
part
says
too.
adrenaline on it.
It says
That doesn't-
adrenaline on it.
It's trade name drug.
Yeah, it says adrenaline on it. So
$9 difference is huge.
it is huge when we're talking
$27 a box times
how many
1,000 boxes.
Oh, yeah, easy. Easy. So we talk about
But usability.
usability, right?
is
So
in
the
our
nice part
favor.
is one of the shortages helped us out. Filtered needles or filtered straws
Yeah.
are on shortage. So the most of our boxes went away from ampules. I believe that's the practice in the ER now as well for UH pharmacies, essentially getting rid of ampules just due to people getting cut. So we're moving to vials. I love it. So if you want to jump right in, talk about mixing it.
Do it, yeah.
So we take
No,
one.
that's awesome.
We take one. Old school way of talking would be 1 to 1,000 vial, or we could say 1 milligram and 1 ml of epi. Remove the cap.
That just made all the pharmacists happy
Oh.
that were listening. Yeah.
Yeah.
That's
sorry.
what they're supposed to be saying, Ray.
Correct.
I know.
You know
I
what's
say both.
sad?
That's why you
I say
said
both.
it.
I
So
say
your
both.
students are still going 1 to 1,000, 1 to 10,000. I'm like, dude, I'm 63 years old. If I can say 1
I can
milligram
make this
and 1
change.
cc,
You
could
can
you
do
help
it.
me out here?
I get it. I always say it both ways. Plus, I like to. I always.
blame-
It's
I
it's
blame
like
my
trade.
habit.
It's
It
like
is.
trade name, generic name.
I mean,
It is.
speaking
It's a
of
habit.
old, by the way, just to interrupt you, look at this. That's a Life
Life
Pack
Pack
5.
Yeah.
That's what I started with.
I started with. I had a 10 for a short period of time, then I went quickly to an 11. I was pretty spoiled. I had an 11.
I've never used an 11 in practice.
I had an 11.
Cool.
Then we went to 12s.
5, a 10, and a 12. Never.
Go on that side of the microphone so they can see you.
All right, let's see here. We'll move this. Scoot Certidose aside for a second. So Derek Frost, one of the pharmacists, he is the pharmacy manager at UH Portage. Him and I made some videos a while back. We did CE with that. So here I have a 100 ml bag of D5, right? Not to be confused with a 250 ml bag of D10, right? So you could try to raise somebody's sugar with this. Not going to be real beneficial. Patient's still unresponsive. We've had some squads try, so just please pay attention, catch your own mistake, right? 100 ml bag of D5 we mix drugs in, 250 ml bag of D10 we give to diabetics. All right, I have my 1 milligram and 1 ml of adrenaline or epinephrine. I
That
am
would
going
be-
to clean.
Like a whole 5 grams.
So we draw the whole 1 milligram of epinephrine up. I then in turn can get the air out of my syringe, clean my 100 ml bag of D5. Excuse me, we're talking about it and joking, and then I make a mistake. And then I inject the 1 milligram of epinephrine into the 100 ml bag of D5. Then we can invert, right? We don't like the word shake, but we can do that. And now I have 10 mics per ml, right? So I'm going to give that dose. Caleb talked about a label. There should be a label in the majority of the drug boxes. If not, we've even emailed that to
Tape.
some of our...
Right on tape.
Yeah.
Yeah, you can write on tape.
Just don't leave it unmarked.
Yeah, we've moved it to, I think we moved it to like a Word document or something. We can email it, prints off like an address label, you stick it on here. And all that does is that continuation of care thing. So it's sitting in their lap, and then you're able to, see that it's a drug. But now I have my 10 mics per ml. I can give 1 ml every 2 to 5 minutes until I get that mean arterial pressure of 65 or a systolic blood pressure of 90. That's what I'm trying to maintain. Then I would just need, I can clean my site again. And then if I wanted to draw up 1 ml.
Probably the worst of the procedure is just making sure you get that needle straight.
Oh, I've seen
It
it, go
is.
through that side port.
It'll go right through it.
I know people in this room that have stabbed themselves in the thumb doing
We
that.
can't do it needlessly with this.
No. No, that's needle only.
So just
Really?
for safety, I'm going to,
This doesn't pierce
that.
through that.
It will not.
and then there we have it. I have my drug. I can
It'll pierce
plug it into my hep block or my IV line running with some fluid, push 1 ml.
that one.
But not that. Okay.
No.
Not that.
No, we can go that way on the drip set. Most of the tubing that's in the drug box now has been moved over to Curaplex brand. It's a 10 drop, and it does have needleless, so I could actually just screw the syringe right into it.
Okay.
We switched away from Baxter is what we did. So
You want to talk about those, or hand it over here? I threw
Yeah.
those out there because I wanted that. I wanted to make sure that I'll take that from you, Ray.
yeah, it's right there. There you go.
So, of course, it's going to be, you're talking strictly from what's going to be in the drug box, but let's be real, what's going to be on the ambulance. Maybe you spike another bag,
Yeah.
get, primary line, your leader bag. God only knows where that tubing came from, whether it was another hospital system, another
Yeah.
hospital, your department purchased it. So, part of the thing we need to be aware of as providers is all these different kinds of administration ports. And of course, the easiest and simplest, you were talking about the full-on needleless, and I think what you're referring to were these lure locks. These are
Yes.
the threaded ones. These are the easiest ones to use, right? You'd need no accoutrement on the end of your syringe. You can just screw that.
No relish or onions?
None whatsoever. You can just, that just screws directly on there. Where we sometimes get into trouble is there another needle over there? Let's just start the standard straight needle too. Thanks, buddy. Where we sometimes get into trouble is specifically, I've seen new providers do this, is they think that there's this soft inner spot of this lure lock,
Yeah.
and they'll put
Put a needle in there?
They'll try to put a needle in there.
That will ruin it, yes?
Indeed, it will. This will get jammed down inside there, and
It'll just
and then
flow.
yeah, it'll just
Then
flow.
it just leaks.
It'll just be leaking out all over your patient, your cot, your pant leg, and of course you feel like a complete winner when that happens. So
I've done worse.
exactly. So nothing gets sent down that inner cannula of these ones with the external threads on them. Those are lure locks. Straight screw on. Now these guys, I don't want to say get a little tricky, but you've got a couple options here. So this is it's a kind of a dual use port. There's both a split lumen, meaning this is pre-pierced in the middle. So blunt cannulas. So here we have
Alligator?
what we would affectionately call, right? What we would affectionately call an alligator clip, but there are just some straight blunt cannulas in there that with the green stripe on it.
Yeah.
If I can have that.
Either one.
Either one, it's the same inside cannula. This is just more optimal things. This
Those
is
are really great for cleaning ears out.
This is
They are
oh,
if you
yeah.
snip them.
Spray it straight in. This would be more optimal if I was putting like another IV set on here and I was doing a piggyback, right? And you could just clip that right on there. But this straight blunt cannula is exactly the same thing, just less those little clip wings, right? And you can push that straight on there. You can ram that through some vials, but you can't get it to ram inside
bag.
of a and this port on
It won't do that?
It won't go. See, it just presses
Ooh.
in there. It won't
Yeah.
go all the way in.
Need
So
a needle.
That still is
And a needle only.
and a needle only on your. And this was a bag of a 100 bag of D5 that we were trying to stick that blunt cannula in. It just wasn't going to go. Likewise, you can also just use a standard needle on these
Yeah.
needle-less ports.
And it won't start leaking?
And it will not start leaking. Nope, that's self-sealing. You can push that, and it will just pull right out. So
Okay.
that split septum
Just
in
don't
there.
do it in that one.
Just don't do it. Yep. If
In
it's
the lower
externally threaded, that's your cue, right? That's your cue that
It's the
that you can own.
Mail in.
Basically, you need nothing else to administer it on.
plumbing.
When we specify what's in the drug box,
Fire term.
there's several of
All of these.
all of these things.
All
right?
of these options. So you're gonna have two drip sets at least provided to you. You're gonna have multiple alligator clips. You're also gonna have the blunt tip, plastic tip needles. You're gonna have a whole bag of goodies the pharmacy really puts together. You're gonna have a multitude of different size syringes, different size needles to draw, also to give, like if you needed to give an IM
IM
shot.
injection.
And then, we have the alligator clips and all these other options. Some of these have been kind of challenging to get lately, I will say that. Especially the alligator clips or the lever lock have been on shortage, back orders. Same thing with the blunt tips. So if there's less of them in the drug box, that's why we're working with our vendors to ensure they're there. I actually had to buy some from a different vendor because the hospital we just couldn't get them.
There should be MAD devices as well.
Supply changes that bad. Yeah, MAD devices as well is another route. Yep.
For a while, we were seeing the BD Integra needles that were self-retracting. Those I don't know.
yeah.
Hopefully, those are gone.
They're
Really?
supposed to be. We're not fans. That's just the design of that needle. I was not.
We
I know
keep them in the
pharmacy.
Pyxis for IM epinephrine so that
Okay.
you can't.
The problem was
accidentally get tracks.
the guys were trying to pull meds up with them, and if you're familiar with them, you press the plunger again after it was pressed, it would retract the needle. So they would pull medication up and go to expel air, and it would retract the needle, and then they'd be like, "Where'd the needle go?" So
Yeah. Just not what we're used
A
to.
learning
Change-
curve, yeah.
Change in the fire service is hard.
Yeah.
Right? EMS world. All right, so that's Push Dose Epi.
That's
I mean,
Push Dose
pretty,
Epi, yeah.
pretty
I always
straightforward,
heard that
very
the fire
simple.
service, they don't like change, and they also don't like anything different.
except
They
for
don't like
dinner.
it the way it is.
Rotate dinner around a little bit. So we already made low dose ketamine earlier. That was on our list, so we don't need to go over that. Push dose epi, and we talked about the olanzapine and the Zofran. Quick note about both of those oral disintegrating tablets. If you read the packaging, it says put it on their tongue, right? And we joke, it's on the tongue.
Right,
ODT.
ODT.
And then let it melt, right? 100% of the time you put something on somebody's tongue and tell them not to swallow that, they
swallow.
immediately swallow it. So this can be given sublingually, right? And then that should be common knowledge. But I've heard some people like, oh, I want to document this as ODT. Like, did you really give it that way? No, we gave it on the tongue. Give it, just write it up as sublingual. You're not going to get in any trouble. We all do that,
We know how.
Yeah, we don't read the packaging either. So the other thing that's on this list here, and this is less of a demonstration.
Also, you can give it an IYM
Oh dear.
in your mouth.
There it
This
is.
is getting better running the controls
right,
here. I like it.
So another thing, it's certainly a pet peeve of mine, is when we talk about TXA, there's a misconception that this drug creates
Oh, it creates clots.
blood clots.
It puts and runs them down this drip set, right?
Yeah, it's just full of clots.
Makes clots. Right?
Makes clots right in you.
What
And-
drug causes clots?
So there's a misconception, and it's been repeated to me numerous times
Yeah?
that TXA, this is what it does: is it clots blood. It makes blood clot better. And I point out to them, if I made you make clots, you would die immediately from a PE, stroke, and an MI, all at the same time.
So
Yes.
let me give you a little history.
Yeah. So
Okay,
let's get
when I was
this
first
out of the way.
in Afghanistan in 2003, we had factor 7, and we would give that to hemorrhagic shock, and that in fact caused clots. And you would actually watch somebody stop bleeding in the areas of injury.
Wow.
And
Wow.
it was profoundly dangerous, but it's all we had.
Yeah.
And so we utilized it on people that the surgeons were not getting control of. And the studies from the military showed that to be not something that was really doing a great deal.
A lot of PEs.
But, and renal artery clots.
Good. Yeah.
But the TXA, the only thing it's going to do is take your plasminogen and stabilize it from converting to plasmin, and it's the plasmin that has that lytic process. So all we're trying to do is stabilize the clot so that during a resuscitative period of trauma, you're just managing clots that need to stay in place. It's not forming clots.
Forming clots, right.
I think we need to get that out of the way.
So, if my department is participating in the drug box exchange,
Yes.
where do I exchange my drug box? Where can I? Let's say Ahuja is my medical control, or Jug is my medical control.
So wherever your medical control is through and where you get your drug boxes. So if you pick up your drug box at a Hooja, you exchange your drug box at a Hooja. That's it.
That's it.
So all of the top of our drug boxes are all labeled. It'll say UH Ahuja, UH Geauga, for UH Portage. It says UHPOR because we didn't want to be confused with Parma, obviously. So we kind of broke away from that. I believe Lake went with like UH Tri Point or in UH Lake. So wherever you pick up your drug box from, wherever the label on top of it is, that's where it needs to go back to do an exchange. Biggest thing with the drug boxes is these drug boxes are built to be able to be used multiple times, right? So there are 4 ODT Zofrans in that drug box. There are 3 vials of 4 milligrams of Zofran in there. There's multiple vials of Epi. There are 2 bags of D5, 2 bags of D10. So our goal is for you to utilize the box on at least a couple patients. I always tell people utilize the drug box, and I always get that question, when do I go from a yellow seal to a red seal, right?
When you
and
can't run a call with it.
When you can't treat another patient, right? Just
Right.
common sense. Same thing with the BLS drug box or the commonly used drug box. If you can't treat another patient, it's time to get a new drug box then.
Right.
There's only a couple times I caution newer medics under our department that, like Narcan is one. If you use a couple Narcans, there might be 1 or 2 left, but maybe it's a good time because we might run into the carfentanil or something that requires a little more. But we do have the basic box too. It has Narcan.
It has Narcan in it as well.
Yeah, it has
so
Narcan as
there
well.
are backups to some.
Yes. I would say that's what we use the BLS drug box or the commonly used drug box for is, you have the 2 doses of Narcan. We use that a lot. The
And I think
EpiPen
we went away
is
from
in there.
Go Nitro, right? We're back to Nitro tabs. So
Correct. We're back to sublingual nitro in a little bottle. It has the tamper tape on it. That company essentially no longer is in business. So.
which is unfortunate. I did like the Go Nitro because you had a true Nitro dose and not.
Guaranteed.
Well,
what
I
might
don't
have been
know
on
what
the bottom.
happened. That was such a nice product.
Yeah.
It was a great product. It was stable, like just the stability of the product.
Unless you were giving it with CPAP, which was the only issue.
That was about it.
Yeah.
Yeah. Crop dusting your.
Oh.
Everybody's got headaches in the squad.
It's like a leaf blower. You just put at the end. It's going in eventually.
Blood pressure's the best it's ever been, but
Yeah, that's a downfall. But back to your point. Yeah, wherever you're picking up your drug box, that's where you need to exchange it.
when those get exchanged, what happens in the background? I mean, how do they know what was used and
What needs replaced?
How is the paramedic or the advanced DMT assured that the next time we crack that drug box open, that they're going to get all the same product, right?
So each hospital is a little bit different. I could speak to Portage probably the most just because I was there a lot with our pharmacy manager, Scott Naples and Derek Frost. Scott's now the East Side manager. Squad comes into the emergency department. They can walk up to any nurse. They obtain the key out of the Omni cell. They exchange their drug box. They're given a new drug box. They put their new one in the ambulance. We take the used drug box that's either tagged yellow or red. And then our pharmacy staff will come down every so often, pick up the drug boxes that are used, take them back to the pharmacy. As soon as the drug box returns to pharmacy, we have kit check. So we've talked a lot about the RFID tags that are on a lot of the drugs. These little tags right here, if people can't see them because they're hard to see, a little RFID tag. Kit check essentially looks like a microwave, for lack of a better word. It's a blue cabinet. We will open the cabinet up. If you have an ALS drug box, we will fully open the drug box, open the lid, tilt the shelves, push it in the blue kit check, shut the door, and there's a computer connected to the kit check. We're able to hit a button. It scans all of the RFID tags in the entire box.
That's kind of why you shouldn't throw wasted
Yes.
Yeah.
boxes back in.
It'll
Yes.
read as full.
It'll read as full. It doesn't know that, like using your needle package as an example, it thinks there's a needle in there. It's just going to scan that tag 100% and it's going to...
Is that
It's gonna
been
think
a
it's there.
problem?
Not really.
I think at first a little.
At first, a little. I think people were used to kind of putting their garbage in the drug box, unfortunately, and we don't want that. It's not safe for the pharmacy staff.
Yes.
We definitely don't want any needles in there. We don't want a needle stick. But it hasn't been as much of a problem the current date. I don't think so. I think we kind of weeded that out in the beginning.
Let me ask you this: on as far as like QA concern or narcotics use, when you crack the smaller box inside the big box,
Yes.
what happens behind the scenes there as far as, is there a trended use being looked at? Is if somebody's
Yes.
giving ketamine every call or Dilaudid every call, how does that happen?
So let me answer the kit check thing fully first, and I'll come back to yours, Caleb. Once we put the drug box into the kit check, we hit the button on the computer, about 30, 45 seconds it takes. Computer scans all the RFID tags in the whole box, tells you everything that's missing. Plus side of that is we also track the lots so much more accurately now. So if there's a recalled medication, the coordinators at each hospital, the pharmacy manager's going to get an email, and it's going to say, at a Hoosier pharmacy, Solon Fire Department has a drug box the owner owns recalled, and it's in box 55. Box 55 needs to come back to our pharmacy right now. It's instantaneous.
Sure.
It actually works with McKesson, who we buy a lot of our drugs from, works with the RFID tags. It's instantaneously. It happens in the background. I don't even have to do it, right? Back to answer your question. So we can track it. We can see how many times a narcotic's been used, how many times any drug has been used through kit check. The nice part is when you return that drug box, we know where it came from because we track it 100%. So we're able to log it on that system right now. And like Dr. Spanner said, we have thousands of drug boxes.
Right.
We're in the 400 or 500s just in Ravenna. Geauga is probably the second busiest pharmacy next to Portage. So we can log in and we can see every single drug box where they're all at. The commonly used drug box or the BLS box, ALS boxes, we can see where they're all at. You can track it. If one department is using a lot of a narcotic, it'll be a red flag. We can also catch that as the medical directors or the coordinators through QA, through our pain medication, a higher use of fentanyl or a higher use of ketamine. We can do trending with that. So I mean, we have a very robust process, I think, to catch any type of issue. And then if anything's missing, the whole track history of where that box was is just found so much easier. Paper, before we had this mound.
Yeah.
And it would take 5 hours to try to go through a stack to find, where's box 55?
But they're still putting their run reports in there, yes or no?
Yes. So
or because of the EMR, they don't need to do that?
So we talked to the State Board of Pharmacy. They still require a run report for a narcotic to be used. We have set it up in some of the EMRs, in some of the programs with Health EMS. I worked with Conneaut in Geneva. When they're done with the run, they can hit another button and it faxes it to the pharmacy. So if they're unable to put the copy of the run sheet in the box, at that time they need to hey, I gotta go run another call, or I gotta run out. I need my box right now. We exchange, and then when you're done with your run report and you hit you're completed, it'll then fax it to that Hoosia's pharmacy or Geauga's pharmacy, wherever you guys use. But right now we only require a run sheet if a narcotic was used. That's the way the board wants it. They like the wedding signature.
Controlled substance.
Controlled substance, sorry.
I've had people stumble on that. It's like, well, it wasn't a narcotic.
Yeah.
Was it
Controlled substance.
Yeah,
Yes.
we're
controlled
using,
substance.
Yeah, so anything on the DEA schedule, Schedule 2,
Yes.
Schedule 3, Schedule 4. So our benzodiazepines, our narcotic analgesics, and ketamine all fall into that.
Yes, and to go with that, we also need the waste form filled out inside the drug box. So there's an accountability form for the little box. There's an accountability form for the big box. Like we talked about our ketamine earlier.
Yes.
Maybe gave 10 for pain, but I wasted 490 milligrams of ketamine. All right, ketamine. I wrote given 10, wasted 490. Print your name, sign your name. You can ask a nurse at the receiving facility. Some of them will not sign because they did not want you draw up the medication. I get that question a lot. What do I do then? That's what your partner's for.
Yep.
That's what your partner's for. You're able to do that. And
And your partner doesn't have to be at the same level of care. The partner was a witness to the draw.
No, they're a witness to you, essentially.
So, and I've run into that
wasting.
where they're like, well, I'm a
Yes.
basic and a medic. No, your partner can sign for that. It was just a witness waste.
Yeah, it's just a witness way saying, I put it into a sharps container at their facility. I put it down the sink. I wasted the medication. I didn't give it to anybody to keep it. Any use of a narcotic will immediately turn your box red, right, or a controlled substance. So if you use any controlled substance, it's automatic red tag. We've been firm on that, and it's assured. We don't have any problems with anything going missing.
Diversion,
or anything.
yeah.
Or diversion. No, we have a whole
the
unit.
the fancy term for theft.
I actually work with the diversion unit now. We have meetings at UH to ensure, that the audit trail is perfectly fine. Everything we do is copacetic. We have great oversight, not only from our end, but also pharmacy's end too. So it's like double oversight.
I got to play devil's advocate here.
Yeah.
So if I signed electronically in HEMS for the waste, I don't have to fill that form out, right?
No, you still need to
Oh,
fill
I
the
still
form,
have to fill the
right?
form out.
I get that question a lot.
Yeah,
I know, it's terrible. I know.
I'm baiting you here.
No,
Well,
I
I
know.
feel like that's redundant.
Yeah. Oh, I understand.
That doesn't, HEMS does not meet with that electronic signature,
does
the
not.
positive identification requirement in the state of Ohio.
Correct.
So, I mean, it doesn't hurt to do it,
No,
but
it's good.
it will not check the box for positive identification of that, and it has to be that wedding signature that has to go back to the
Yes.
pharmacy
Yep.
inside the box. Now, your nurses at the hospital can sign electronically for their waste
Right.
because
It's
they badged in
Positive ID.
and put in. They did
Yes.
a two-step process
Right.
where HEMS is only a password.
Correct.
It's not that two-step process. So.
No, and I know our Health EMS team was working on that with the Board of Pharmacy, but essentially we would need to seek their approval to be allowed to do the two-step or positive identification.
We're not there yet. So
No, not yet.
Do the
That's
wedding.
something- Yeah, hopefully we'll get there someday.
I hope. Yeah, no, that would be that'd make life easy. And
That's
it'd be nice
the-
to have all that in one spot.
That's the kit check process, and we'll take back there. But yeah, please don't put any garbage or used boxes
Yes.
back into the drug box because it does still get checked by a pharmacist, by a live person, if you will. We don't just solely rely on the computer to make sure everything is correct, but it does decrease their workload, increases the turnaround time to EMS. So it's been a great tool that we've implemented across our system.
Okay.
And its safety is just paramount with it. It's a great tracking device.
Mm-hmm.
Any other operational drug box things that?
Certidose.
Certidose, yes.
So have you guys seen the video for that?
It's
Yes.
really good.
I mean, it's phenomenal.
Yeah,
It's-
it's like
and it's
a
Any,
two short,
con-
30
any
seconds.
conversation we have about Certidose, we have to send them to the.
Mhm.
Yes.
So that would be
Maybe
good to put
link-
on the
put link or-
podcast.
yeah.
That'd be great. Put that link
It's
right off their
perfect.
website. It's a great product. So we've had it for maybe a little about pushing maybe 2 years now.
I think it's close to 2 years.
2 years now. Certidose is it's their PAL syringe kit. They do have two options. They have an epinephrine one for pediatric anaphylactic reaction, and then they have PAL Certidose for cardiac arrest. You
Is
will
the
see
pediatric anaphylaxis an IM epi type thing or no?
it is.
Okay.
It is. It's a.
I haven't seen that.
It almost looks like it's
A
just a syringe that's actually has the color coding tape on it.
Oh,
and they'll
nice.
sell it to you with an ampule of adrenaline or epinephrine in the kit with the tape and stuff. So it's actually it's
That's
a
cool.
really slick product.
It's all color-coded
really
on
slick.
that.
It's kind of like a little glucagon kit that you just.
Yeah. Realistically, yeah, that's a great example for it. 100%.
So, again, they can see this. What is Certidose? You said it's used for.
Yeah. What is this in the bottom of our drug box?
Yeah.
What is this? Do I
It's
need to
just the
use that?
box.
God, but, we have to. Again, we have people that can't see this. We have to explain what we're looking at here, and this is a color.
I think you have to see this.
This is a Broslow color coded.
100%. Broslow color coded
Broslow
product.
color coded
Yeah.
accessory that snaps on your pre-filled
Yes.
epi, atropine, or lidocaine syringe, and gives you that Broslow color code right on the side, so you can, as you push it to that particular color coded line on the, it just slides right over, and that's what you're gonna.
Yeah, I'll show you guys how to
us
use
here,
it.
yeah.
One tidbit of a change, they do use clear tape to seal this, and this goes in the bottom of our drug box. So we're going to put tamper tape over this now, almost like we use with the nitro, just to ensure it's not broken. If you guys utilize this on a run, take it out of the drug box. We don't want any of this put back in. Back to that comment. I don't care if you put it on the shelf in your ambulance. If you're one of our squads, keep it. Great.
Keep it for training, yeah.
Just don't put it back in the drug box. We'll put it. The pharmacy will put a new one in. The first thing you pull out, you see these little labels
To an
that say
extent.
baseline. Yeah. Here's our Broslow measuring tape. So we will
Comes with the kit.
comes with the kit. You're gonna measure the child, and let's go with our first drug, right? Doesn't matter if we're in VFib, VTAC, asystole, PEA. My first go-to drug is going to be epinephrine. Little tidbit about the opening the boxes. I gotta give a pharmacy plug here since I hang out with those guys so much. It has a little label that says "Open here." So if you open on this side, they slide right out of the box. If you open on this end, it's very difficult to
It
get
is
out.
indeed.
A lot of people don't pay attention to that. So our little baseline sticker here needs to go on the end of our our medication.
Mhm.
What I've found to be the easiest is to remove the cover first, because you don't want the sticker going on your little
over the
rubber
cap.
your little cap or your rubber
Yeah,
stopper. It's
So
gonna
you
rip
still
off.
get to do your.
Yeah. So I would do that first. You could pop your top first, if you will. Since I don't have
Nails.
nails, it's a little difficult for me. But this little sticker for the baseline needs to go just flush with the end of this syringe. Is the goal, and that's why I don't like to utilize the. That's why I don't like to utilize the cap.
That
I want
cap,
to remove.
yeah.
Right. At that point in time, you can assemble your syringe. So I can put it together. And then now I'm going to choose my syringe holder, if you will.
So
or
that
it's
was
gonna slide over.
epinephrine.
So that's
So
epinephrine.
show the camera the epinephrine.
So epinephrine's
gray.
color coded. It's color coded to the box.
Yep.
Actually,
Mhm.
they use the same type. Epinephrine's listed on the not only the sticker, but it's also listed on the side of the syringe.
Mhm.
Then I could confirm with my medication that I'm using is epinephrine.
Yep.
I take my sticker off, slide
Click.
it over,
Should hear a click.
I click. Now it's flush.
Yep.
And now that little baseline sticker that we put on here onto the end of our med, I just need to bring it up to the baseline. So I need those two lines to meet.
Let me see. Excellent.
So I need to make that flush. And then as we measure our child, that is going to give us our color,
chart, yeah.
our color
Yeah.
chart, right? So I can remove this, and then I am able to, let's say if our child fell into the yellow, I just simply need to push that to the 1, right? And I've given my first dose of epinephrine.
Let me see. Okay.
So very simple product. Now, 2 minutes of CPR. I go back to my rhythm check. I'm still in, let's say, VFib, systole, PA, doesn't matter. I can give I give my epi every 3 to 5 minutes. I'm already ready. At that time, I can push from the end of the first line to the end of the second line. Now I've given my second dose of epi. So I think this product is excellent because
That's so easy.
it's super easy in a high stress, low frequency.
Low frequency.
Yeah.
Right? It's high stress.
Thank God, low frequency, huh?
So it's a great
And this
product.
is not being done in the system, just on the pre-hospital view.
I believe it is used just pre-hospitally right now, yes.
That's unfortunate.
We
That's
also,
really cool.
We also have the atropine, and then we also have
And
the
they all work
lidocaine
the
pouch.
same exact way.
Yep.
They all work the same exact way, and then all of the syringes that UH Pharmacy buys for us are compatible with this. So that's why we
Excellent.
we don't ever want to change those because that only works with certain syringes.
Right.
But-
I've got another style down here that this would not work with, but to your point,
Correct.
once we put Certidose in, they had to stop buying these.
Yes.
This came, this is eons old. This is probably this expired.
That was when atropine was invented.
And so it will only work with those Hospira or those IMS glass. These are all plastic.
This one works with Tyrannosaurus Rex egg.
Oh boy.
So just phenomenal product. I can't speak highly enough about it in all honesty. Just great tool if you have that pediatric cardiac arrest. The color does coincide with our pediatric dosing charts across the top from the protocol, coincides with the Broslow chart. So its interoperability is really key here to
So-
deliver the correct dose to a pediatric patient safely in that high stress situation. So
Safe and simple.
100%.
Safe and simple.
So you mentioned there was one for anaphylaxis as well. Is there talks about getting those?
So I don't know if we're gonna look at that one or not. It's interesting to look at those. I think it's a great little kit. There was actually
Although,
there was a piece done.
frequency.
Frequency with it was something we looked at when we talked about
0.01
pediatric
mins
EpiPens.
per kg IM. It's not super hard.
It's not, but again, high stress.
High stress
But you can go to
makes
the
it
website
simple.
and get them, and they do work, I believe, with our Epi. So
I mean,
Yes.
it's not as accurate, though, when we're doing intravenous care. So I always tell people under 30 kilos, 0.15, over 30 kilos adult dose.
Yeah.
I don't do math.
Yeah,
And I
get it.
definitely don't do it in a high-stress situation.
Yeah.
So that's always been my go-to for IM anaphylaxis. Less than 30, you're getting Epi Junior. Over 30, guess what?
Yeah.
Adult dose. Here we go.
Yeah, and a lot of people kind of tail off of that would be the EpiPen. Everybody's like, it's an adult EpiPen. It's really not. So it's actually, you can utilize that EpiPen if they weigh
Absolutely.
66 pounds or more. A lot of people don't know that. A lot
Yes.
of providers don't know that. And you'll hear a lot of methods is, you know, most parents always know what their child weighs. Maybe when they're born or maybe when they are currently now. We'll see. It depends on the chicken nugget intake. But, you know, if you look at it.
Hey, I resemble that remark.
My son's like diehard chicken nuggets or mac and cheese. So
I like that kid.
one of the things a friend of mine, Matt Ozanich, always used to say, if you could pick the child up with one hand, they're EpiPen Junior. But if it takes two hands and you got to bend over, they're probably,
I like that.
adults. I'll give it to Matt. He works for Registry now. He had a great point.
That's
about it.
actually pretty cool.
So
I like
thought
that.
I got to give credit to him. Ozanich was really good about that. But it kind of goes back to your thing, just simplistic. If it's two hands and you're bending over and you want to make sure your back's square to pick that kid up, you're probably good to go ahead with the 66 pound. Just I am holding for 10, you're good to go. So, but yeah, good product. You guys got
Nice.
any questions about this or not?
Another point I wanted to make is you referenced in the back of the protocol book in the appendix tab number 1, which is the medication section. This is just for resuscitation purposes, but
Yes.
obviously we can give many a med to a sick child that doesn't necessarily fall in the resuscitation category. In that chart, and I think this gets overlooked sometimes,
Oh, yeah.
same color code,
Yes.
same breakdown. All of those color codes follow over from the are hyperlinked from the pages, but most importantly, based on the standard concentration that we carry, not only does it tell
Every
you
drug.
not only what
I love that.
what
too.
dose, not only what dose,
Yes.
but how many milliliters of that dose to draw up. And we have to, give the public thanks to Bill Bernhard.
Oh, yeah.
Yep. Bill did that entire.
He sure did.
Assistant chief at Highland
Highland
Heights.
Heights.
He took the time to.
He
do
took a
all-
lot of time to do that. I
he
remember
took-
when he
yep.
was doing that.
Yep, he took the time to do all that math for us, and to this day,
We're still using it.
oftentimes a product will give you the dose, but then it's still incumbent upon you to look at your concentration, and then let's be honest, that's where it's going to fall apart. That's where a mistake is going to get made. We can do simple math to get to the dose, and then to get the right concentration drawn up is where it falls apart. So don't forget, just look it up, right?
Yeah, use it. It's a safety thing, not
It's a
to
safety
not to
thing.
drive home the pharmacy point, or even, Rainbow Babies and Children would say the same thing, right? Because when we dose in the ER to a pediatric patient, 2 nurses are checking that dose to that drug before it's given to that pediatric patient.
Yeah.
So utilize the charts. They're, that 3 a.m. call with this sick kid, and you're going to give them a drug. Utilize the chart. The math has been done for you,
Yeah.
and I agree 100%. We're really good at getting to, I need to give this many milligrams of the drug,
Yeah.
but it's actually drawing up that volume is where the mistake is
you can-
made.
Yeah.
That's where I'll
That
mess it
actually
up.
skips that
Mhm.
asserted dose.
But that's for 3 drugs.
yeah,
Yeah.
I'm just saying.
Yeah. Arguably the highest crisis or the highest stress
oh, yeah.
situations, which is
100%.
why that is a beautiful thing.
And even then, you can take a moment to think. Never hurts. Big deep breath moment.
A couple other just weird things that keep coming up, or that constantly come up, is I often see
Oh my gosh, this just happened.
people.
Carpet jet.
How do I use a
No,
carpet
so
jet?
listen, I
Yeah.
just had a medic come up to me. Doc, this is supposed to be 1 milligram of Dilaudid and 1 cc, and I gave a cc, and you know what? There's a whole cc left. And he came up to me. So, by the way, when I was done, like I had this face like, and he goes, what? And I go, there really is just 1 cc in there. You got to push out that
That
cc
air.
of air. He goes, ew. He goes, yeah, that didn't work. I was like, okay.
Patient's
So,
pain never came down.
Still
We know
complaining.
why.
that's a good point, though. That's so
So
funny.
there's a couple of points to be made with
Yeah.
the carp eject. First of all, there's many people that just do not know how to put one of these things together, and
That's
true.
true. It's true.
It's the God's honest truth. I've had very seasoned paramedics that I've oriented, and they're I make them do it because I know people.
And they
struggle
also
with
don't know that you can draw from it if you need
Yeah,
to.
yeah, well,
Right.
yeah. We can get to that, but and I have in my hand here, a standard carp eject. The only thing that we carry, and correct me if I'm wrong, Ray, is hydromorphone, is Dilaudid in a carp eject. Our fentanyl comes in vials. Ketamine surely comes in vials. Our Versed or our Ativan comes in vials
That's
as
it.
well.
Yeah.
But this is the holdout as we carry Dilaudid hydromorphone. There's 2.5 milliliters worth of graduation on the side of every carp eject, despite there only being 1 milliliter of fill. And if you read right on the side here, it says there's 1 milliliter in here, right? But these come with this plunger pulled all the way back to the 2 milliliter.
Right.
line. So in that case that you were talking about, he had a milliliter of air on top of a milliliter of
It's
agent.
nice that he
on top of
injected
drug.
a milliliter of
milliliter
air.
Yeah, and it's even better that there was nothing untoward came thereafter. But the couple of the points to get this, that, you have to have this. You don't have to have this. The textbook way to deliver this is to use this carp eject carrier, and that's that blue T-handle thing with the plunger that's rattling around in the drug box. And a couple of things I've seen happen is this has to go in tail end first into the carp eject carrier. If you put it in nose end first, there's just a little recess there that clips into. It actually doesn't sit down into the carp
Wow.
eject carrier. And I know of cases where people were trying to force this in here and have actually broken the carp eject and then dumped a milligram of Dilaudid down their pant leg.
There's nothing in medicine that requires force.
Yeah, true.
And this is another good thought.
You're right. So that goes in tail end first. Goes in open end first, I guess is another way to say it. My vision is terrible. I rotate those graduations in the open part of this carrier so I can see it. You can see it through the plastic, but I think it distorts it. So it's just one of those stupid little things that I do to make my life easier. Now on the back of that, plunger inside, it is actually threaded. And when you push the rod and you push the push rod up, you actually need to thread that on there, right? And that'll give you the ability to push and pull that if you need to. Generally, you can get away with just pushing it, but if you ever needed to withdraw a little bit, check patency or something, you would need to be able to pull backwards. This is where things really go foul, is when we stop right here. And what has not happened is, I'm going to take us back apart for a second. Inside the end of this carp eject, the one end is a lure lock, just screws right onto your IV port, and on the other end of this cap, there's just this tiny little needle, and that tiny little needle hovers over top of what is just a typical rubber stopper for a vial, but it hasn't punctured that yet, and you actually have to make that puncture for the drug to go out the end and be administered to the patient. And things can really go awry if we put this together and miss this last step. So again, I'm putting it in the carrier, tail end first. I'm setting it down. I'm threading the push rod into the plunger here. And if I try to take the cap off and push it at this point, I will meet tremendous resistance because that needle on the other end has not punctured that seal. So there's been several cases where they put this on their IV, they push, nothing happens.
It's not working.
Push harder and nothing happens. They push really hard, and of course they lean into it. It pushes down, and then they wind up getting the entire dose worth of drug. So
And the air.
and the air, right?
Yeah.
So what you have to do is, I call this activating it, but you have to kind of collapse that down and puncture the inside of that. And you do that by twisting this blue handle. One half complete, one half, not a quarter of a turn, right? So if the blue and the clear part of this, I've seen people walking around with them like this too.
Come on,
I'm like,
Scott.
I swear to God. You got to turn that all the way till it locks. That actually pinches this together. It pops that
Needle.
that needle into that. Yep. into that. And now this is
Functional.
ready to express the air, right? You can take the cap off that, just express that up to the 1 milliliter mark, because this is 1 milligram per milliliter, 1 milliliter fill. So like you were talking about, we're going to express that air out, and now I just have a bit of drug popping up at the end there. I'm ready to give this. A lot of things that can go wrong. Now, you've done a very nice job, Ray, of appeasing all of our pharmacy colleagues. Now I'm going to make them cringe a little bit.
I get the thing all the time. I couldn't find this in the drug box. I couldn't find it in the drug
It's in a
box.
piece of plastic.
It's there. It's there. It's in the bottom. They're usually in a bag nowadays because people just don't utilize them. And I think the path you're going to go down is the path that most providers utilize.
Right.
So,
And,
yeah. But it is there.
But
Sometimes
this
it's
is
in a bag.
how things happen. I thought that was a really nice way of doing it. It's kind of like if you don't know how Solumedrol works, and I've seen people try to put needles through it. I tried to put a needle through it before the first time. Someone said, "Dad, just squeeze it." I'm like, "Ooh." No, I'm not kidding. You know?
It's one of those
It
things.
doesn't
to live
mean
and
that
learn.
you're a dummy. It means you haven't seen something
Yeah.
before.
Right. But this, you got to do several procedures in a row completely correct
Yes.
for it to work exactly as advertised, right?
You got to break it in.
You're going to break it, all right. But alternately here, and again, we're going to make our pharmacy colleagues and certainly nursing cringe, but you can just tear the end off of this. Thank God it's only water. You can tear the end off this. Again, expose that rubber stopper, and you can just stick a needle straight in there and pull it out.
So much easier.
Now,
It is.
So much easier.
there is one rub here too.
Oh, yes.
There is one very important rub here. Unlike every single
That's
vial,
not hard.
Oh, I don't think it's hard.
I'll tell you what, there's many people that stumble on that, though. There's just a lot of, if you don't use it every day, right? And we only have one drug, right?
Correct.
And if you don't use
That's
the
2
one
days
drug,
of education at the
we used to have
medical
Demerol like that. That came
Yeah.
the same way.
Oh, okay.
I haven't seen that in decades.
the other important part here is you just pull the drug out. You cannot put air in here. Otherwise, that stopper just rockets out of the end, rattles around, and then you aerosolize all the drug, and it's raining down on you and your patient. It's actually
Yes.
I have seen nurses pull drug out of that.
Yeah.
Yeah.
You know, because they don't like
they're
that.
not
Yeah.
supposed to. But I mean, I show in my orientation classes, I put air and I just send it across the room, and it will fly across the room, and you'll lose all the agent as
Yes.
well. So just draw out that plunger will just collapse in on itself, unlike a regular vial where we have to put air into it to get out any amount of drug.
Yes.
You usually pull a milliliter or two off, but without. But
Okay.
So takeaway point from ketamine?
Takeaway point from ketamine, making sure that we realize we have 3 different uses for it. So that's 3 different doses, 3 different routes for 3 different emergencies. And it's really important to know the right dose, the right time, the right patient, the right route, especially with ketamine, because you're getting very different effects at these different doses and routes.
100%.
all right.
Spot on.
Thank you.
Thanks, guys.
Thank you.
It's fun. Thanks, guys.
We'll talk to you next time.